This is Sunnyside Academics, your one-stop for a refresher's guide. Topic of the day, diabetes mellitus. In today's topic, we will be covering type 1 and type 2 diabetes mellitus. Just for a quick refresher, type 1 or type 2 diabetes occurs when there is insulin deficiency. With type 2 diabetes, not enough insulin gets produced or insulin resistance. Symptoms include blurred vision, increased thirst, frequent urination, weight loss, and fatigue. But with type 1 diabetes, the body can't make insulin, which could result from a chronic autoimmune disease that ends up destroying cells that produce insulin. Symptoms are frequent urination, thirst, and weight loss. In our previous lessons on carbohydrates, we talked about gastrointestinal digestion of simple carbohydrates as a source for dietary glucose. We emphasize glucose as a single unit sugar of carbohydrate. Glucose is a primary source of fuel for energy. In our body system, energy is vital because it powers metabolisms. Without energy, our system's metabolic functions cannot be sustained. However, the body has devised other means for obtaining energy in the absence of glucose during fasting. Free fatty acids, for instance, are known to be a secondary source of fuel for energy production. To discuss the physiology of blood glucose regulation, insulin and glucagon hormonally regulate blood glucose concentration. Insulin acts to avoid hyperglycemia by stimulating glucose uptake into tissue cells. Glucagon, however, has a direct and opposite effect of insulin. During fasting, or in the absence of dietary glucose, glucagon stimulates glycogenolysis and gluconeogenesis so as to raise low blood glucose levels, hypoglycemia, and maintain blood glucose homeostasis/physiological balance. Therefore, alterations in the secretion of glucagon and insulin can have an effect on blood glucose concentration. Now we discuss the pathophysiology of diabetes. Insulin deficiency leads to diabetes mellitus. Depleted insulin secretion in type 2 diabetes means that there is not enough insulin to efficiently work to maintain blood glucose. As such, therapeutic interventions are proffered to support homeostasis. Oral hypoglycemic drugs, such as sulfonylurias, biguanides, meglitinides, alpha-glucosidase inhibitors, and thiazolidinedians, etc., functions to support blood glucose balance in type 2 diabetes. Although oral hypoglycemic drugs does have different mechanisms by which function to maintain blood glucose. Choice of administration of drug will depend on a patient's response to a particular hypoglycemic drug. Total insulin deficiency, as seen in type 1 diabetes, is managed by insulin administration. Implications of diabetes mismanagement. Diabetes, ketoacidosis. Ketoacidosis can be caused by diabetes in cases if inadequate management of diabetes leading to excessive or prolonged oxidation of free fatty acid by the liver. Obviously, an increase in body acids can have implications in maintaining the body's pH. When insulin is not stimulating glucose uptake, that is, when glucose concentration is below those required for tissue uptake, insulin initiates a hepatic effect via a series of biological processes to reduce glycerol concentration, which is a substrate for gluconeogenesis, and free fatty acids, which are a substrate for the production of ketone bodies and a necessary fuel for gluconeogenesis. The same effect may not be seen with diabetic patients lacking insulin, and so gluconeogenesis goes on unreduced to raise blood glucose and free fatty acid breakdown. Leading to ketogenesis can go on unreduced and can lead to ketoacidosis. Diabetic nephropathy. When diabetes isn't well controlled, it can lead to nephropathy. Maintenance of blood glucose concentration is key in this regard. Diabetes retinopathy. It is said that mismanagement of diabetes can lead to retinopathy. Sunnyside Academy, a refresher's guide.